We're going to talk about autoimmune and inflammatory disorders. These should be chapters 47 and 45 in the Ricci textbook. First, we're going to talk about inflammatory skin disorders, and these include diaper dermatitis, which is, just a diaper rash, and atopic dermatitis or eczema. So, diaper dermatitis, the pathology is that it's an inflammatory response to a skin irritant that results in skin cell hydration disturbance. Basically, diapers increase literally the use of a diaper increases the pH level of the skin, which then activates fecal enzyme reactions, which then leads to more skin breakdown. So we can see this be red, shiny, bumpy, scaly. Sometimes it is just the response to the skin irritation and wetness and feces. Other times there's a development of yeast that occurs. In those situations, we would use obviously nystatin ointments to treat it. But a normal everyday diaper rash, the topical products that we're going to use are like barrier creams, just like you use on your adult floors for any adult who is in a brief. Barrier creams that have zinc in them. There's one that's literally called butt paste, and that's my favorite. It's super thick. It's hard to wipe off, and that's kind of the point. We're going to avoid soaps that have fragrances. We are going to kind of just avoid soaps altogether. And any baby wipes need to be fragrance free and basically just water. So I'm sure any of you guys who've been on peds, you've noticed that there are water wipes and then there are diaper wipes. So the diaper baby wipes have fragrances and other things in it, whereas the water wipes, they don't. It's fine for parents, if they can't afford things like that, to just use a wet paper towel. That is fine. Use a rag. Just don't use anything other than water. We're going to advise parents to do frequent diaper changes, to let their babies air dry, especially if the diaper rash is severe or getting worse. In the hospital setting, I will put the baby on a big chucks, strip them down, and cover the top of them with a towel. And then they can poop and pee all over the place, but they're basically open to air. And A, the babies love it, and B, it really helps to clean up the dermatitis. We also need to make sure that parents understand that baby powder is really kind of a no-no. So we don't want to use baby powder on any baby, ever. Don't use it on their skin, don't use it on their feet, don't use it on their butts, don't use it on their necks. You can use a cream that turns into a powder form, but you should not ever use baby powder, and that's because of the respiratory particles, or the particles that are going to get into the respiratory tract and then potentially cause disease, pneumonia, cancer later in life. So don't use them. If Johnson & Johnson baby powder can cause cancer in your uterus, it can cause cancer in your lungs. So just tell parents absolutely not. We also don't really want them to use any powder that can get into the respiratory tract. So if they have a cornstarch, that's going to do the same thing. And we don't want babies breathing that in. So just no, don't use it. One thing that does help a lot, and I learned this from my pediatrician when my children were little. You can use like Malox or Mylanta if the purpose of it is to take the acid out of the GI tract. It's going to work on the skin as well. So if you get my Lanta or Malox and you put it on, I always liked the minty flavor because it smelled clean and it had cooling properties, but really you should just use something that's unscented, just a straight Malox or Mylanta. Put it on cotton balls and dab the diaper dermatitis with the cotton balls that have the Mylanta or Malox on it, and it's going to take the sting out of the skin. It's going to pull the pH back to normal. So the redness is going to go away. It's going to be cooling, and it kind of does develop a chalky, powdery texture after use, but it goes on as a liquid. Just try it. It's great. Now we're going to talk about eczema, which is also known as atopic dermatitis. Um, this one we tend to see, as far as the pathology is concerned, I call it the triad. It's the inflammatory response triad, which is a male person of color with allergic rhinitis and asthma. That child is going to be very likely to also have eczema. So if you have a child coming in who has severe eczema, check their lungs. They likely have asthma as well. Or they've been having lots of periods of what they call reactive airway disease before 2 years old. They have frequent allergic rhinitis symptoms. Um, so yeah, it was hard to find a picture of a little baby that is a person of color with eczema. So that's why this chunky little white baby is on here. Um, but you can see he has severely dry, scaly skin with cracks and redness, and you can tell he's been scratching it and itching it, which is bad. So the cues that we're going to see in our kids with eczema is chronic itching, redness, scaliness. They're going to have disrupted sleep patterns and irritability because they are so uncomfortable. They're going to have rashes on their face and scalp and wrists, the inner sides of the arms and the legs. And then as they age and get into older childhood and teenage years, the eczema is going to try to like uh, make a focal point of their bendy parts, like the inside of their elbow or the area behind their knees. Bendy parts. Okay, so these are the labs that we're going to see being done with a patient who has eczema. Most of the time, we're just going to diagnose it based on sight, like sight and symptoms. We've got it. But they can do serum IgE levels, and they're going to see those be rather elevated. And then they're also sometimes going to want to do allergy testing of the skin, which is macabre. It is so just mean and painful, but it's a good thing to do to be able to find the trigger or the thing that is making the eczema worse, which here in Kern County, it's just living in Kern County. So when we talk about nursing actions, we need to promote hydration of the skin. So we want them to drink and be hydrated from within. We want to make sure that when we're promoting hydration on the outside, we remove all of the skin damaging things like perfumes, hot water, um, fragranced soaps, fragranced creams, moisturizers, synthetic fabrics. So we want to make sure that we bathe these kiddos at least twice a day in tepid water, not cold, not hot, tepid. We're only going to clean with mild soap the areas that are actually dirty. Everything else, leave it alone. You don't need to scrub their little cheeks or even put soap on them if their little cheeks are not dirty. We are going to pat them dry or let them air dry. And we're going to apply ointments that may be prescription with creams on top of that, with a moisturizer on top of that. Women who are in the beauty scene know it's called slugging, where you basically cover your body in Vaseline or Aquaphor. So we're going to do the same thing to these little babies with eczema. Cover it up, make like an occlusive, super wet, airtight cover for their ointments and creams to sit underneath. Then, like I said, cover them in a light cotton pajama, light cotton clothing, because we don't want them to overheat, because sweating makes us more itchy. It dries out the skin even more. And we also need to make sure that their bedding is light, loose, and made out of cotton. They should not have all of the synthetic, cutesy, fuzzy things on their beds. That's just going to make their eczema worse. The triggers that an eczema patient is going to have are usually the same triggers that an allergic rhinitis patient would have and an asthmatic. So their triggers can be things like cockroach exposure, mold, allergens, plants, dust mites, pollen, smog. So like I said, Kern County, and then also stress. So we want to try to alleviate stress. We're also going to maintain their skin by keeping their fingernails short, well rounded, avoiding tight clothes, and we can give them antihistamines at night and some distractions. So Benadryl before they go to bed, after they've had their bath, their second bath. We've done their little nighttime routine by covering them with creams and slugging them with ointments, and then give them their Benadryl, get in the bed, and read a book, play a game, something calm, and hope that the diversion and the Benadryl will help. Okay, now we're going to talk about SCID, which is severe combined immunodeficiency. This is a potentially fatal, super rare, X-linked autosomal recessive disorder. Basically, it's bad. SCID is characterized by a complete lack of T cell and B cell function. So think back to what our T lymphocytes and our B lymphocytes do for us. And now get rid of that. It's not good. There are 5 different types of SCID, and the type depends on the exact genetic malformation or defect. So when it is diagnosed, there must be emergency intervention. There is some gene therapies that have been started, but until that becomes more mainstream, we just kind of have to help the kid along until a hematopoietic cell transplant can be done. So some of the cues we're going to see in these babies. They're going to have chronic diarrhea, like not linked to anything, just chronic diarrhea. They're going to be failure to thrive. They're going to get severe infections everywhere that they can possibly get an infection. They're going to have persistent oral thrush because their bodies cannot fight off anything. They're going to develop pneumonia frequently, and we're going to see really low immunoglobulin levels in the serum. These are our actions and interventions. We prevent infections as best we can. We're going to teach the families and everyone involved in their care to do super good hand washing. They're also going to have to limit completely any exposure of the child to anyone outside of their immediate household. So if grandma and grandpa don't live with them, grandma and grandpa can only visit through Zoom. We cannot expose this child to anything. Anything. They are basically a little tiny, like AIDS patient, except it's not AIDS, but it's functioning the same way. They have no T cells, no B cells, no way to fight off any invaders. We try to provide them with adequate nutrition frequently because of their failure to thrive and their inability to just not be infected with something. They're going to be poor feeders. So we might place a Mickey button, we might put in an nasogastric tube or an orogastric tube, and that's how they will receive their nutrition. These kids can have IVIG infusions. They do need to be monitored for adverse reactions. Adverse reactions to IVIG does not always occur with the first infusion. It can occur with any infusion. So if any of you ever give IVIG, just know that there is always the possibility of an adverse reaction, no matter how many times they've received it. IVIG is intravenous immunoglobulin, and these kids don't have immunoglobulins, so we can give it to them. These kids can also have stem cell transplants. So post-transplant, we have to monitor them for graft versus host disease and make sure families know what that looks like. The first sign that we normally see is a rash on the palms of the hands and the soles of the feet. We give as much support, both resource-wise and emotionally, that we possibly can to these families, because this is rough. We give CMV negative irradiated blood and platelets. So basically, if this little child comes in contact with blood that has cytomegalovirus in it, they're going to die. So we make sure it's CMV negative irradiated blood and or platelets. The complications that a child born with severe combined immunodeficiency will suffer are frequent and possibly fatal infections, reactions to their treatments like IVIG or the stem cell transplants, and death. And then the management of these kids, again, is IVIG infusions up and until they can have a stem cell transplant or bone marrow transplant, and then we also give them long-term antibiotic therapy. Juvenile idiopathic arthritis. Idiopathic is my favorite medical term. It means we just don't know. We're so dumb. We're a bunch of idiots. So it used to be called JRA, juvenile rheumatoid arthritis. But then they realized that most of these kids did not have the same laboratory workup that an adult with rheumatoid arthritis would have. They frequently do not have positive rheumatoid factors, and only sometimes do they have positive anti-nuclear antibodies or ANAs. So, idiopathic in that sometimes it's hard to diagnose. So it is an autoantibody autoimmune disorder. The autoantibodies target the joints, and basically our body's just attacking itself. So some of the cues we're going to see: pain, redness, warmth, stiffness, swelling. These kids might have visual disturbances. They might have other organ involvement, like their kidneys. They might have a real irritability and fussiness because of the pain. These kids might refuse to play. They might refuse to jump or run. They might have a pretty pronounced limp or refuse to use their hands or bend their arms. It really just depends on which joints are affected at the beginning. And it's going to be really hard to get them out of bed. Frankly, it's hard to get me out of bed because of my autoimmune joint issues. We want to ask families about any fevers that are greater than 39.5 Celsius that occurred for like more than 2 weeks, because sometimes this is precipitated by illness or severe fever. I didn't have any risk factors in here. I think pretty much anybody could have it. Here's what we use to diagnose it. History and physical. We're going to ask within the history if there have been any severe fevers, any massive sun exposures, any like super bad sunburns, any viral illnesses that just lasted a really long time. We also want to know if it kind of comes and goes, because although it's a chronic disease, they're going to have remissions and flares and remissions and flares. So we want to watch for that, where parents say, I don't know, they were doing okay for a couple of months, and then here we go again. We might have, like I said in the previous slide, a positive rheumatoid factor, but it's not common. And the ANA does not have to be positive either. We're going to see mild to moderate anemia and elevated ESRs. So the actions or interventions that we're going to do as nurses is that we want to promote normalcy as much as we can. We want to maintain their mobility with pain control and inflammatory control, which means medication compliance. So we use NSAIDs, corticosteroids, and anti-rheumatic meds, depending on how severe the disease is. These kids might not always show us just how uncomfortable they are, so we really need to do good examination of these kids and their history. So we need to promote rest, comfort, and play at the same time. So the kid needs to know that they need to rest frequently, and they need to maybe, and this is going to be dependent on each child, what they prefer. They might get out of bed easier if they have heating pads or warm compresses. Maybe a warm shower in the mornings might help them with their pain and mobility levels, and then they can take all their medications, and then they can go to school and try to be a normal child. And then when they come home and they're getting ready for bed, they need to comfort their body. Maybe they need to use ice on those sore joints and swollen joints that get worse from activity. We also want to make sure that we really prevent social isolation in these kiddos, because they tend to, because of their pain and because of their meds and because they might walk differently or be unable to do certain things like throw a ball or catch a ball, they might be less willing to have friends because they're avoiding the social conflict or the bullying. So we want to try to make sure that they're not socially isolated, really encourage them and parents to get them involved in things like maybe art class or swimming. Swimming's a great one. Um, so as long as we are providing pain relief and we're managing joint function, getting lots of rest, and doing things that make us joyful, we should be okay. That's not to say there's not going to be flares. We want to limit stress. One of the things that's a really good tip for kids who have arthritis like this is having two sets of books. And the school nurse needs to be aware that this is something that should be done for this child. So they need to have two sets of books, one at the school and one at home. That way the kid's able to do homework without having to carry big ol' heavy chunky books back and forth from school to home. That's hard on a normal child with absolutely no joint involvement. It's extra hard on a kid that has joint involvement. We can tell the kids about support groups and summer camps that they have for kids with juvenile arthritis, which is really fun because then they get to make friends who have the same life skills and challenges that they do. And we're going to ask the families to also receive support by support groups like the American Juvenile Arthritis Organization, and that's just going to be really helpful to them overall. I'm going to talk about the management first. So we want good control of inflammation. We want good pain relief. So these kids might have more than just Tylenol and ibuprofen. They might need to have days where they can take Percocet, Norco, things of that nature. We are going to try to do non-medication based interventions for comfort and pain as well, though. We're going to do as much mobility aid as we can. So we might use splints, braces, orthotics, make sure we do really good skin investigation underneath that if they're using it on a long-term basis. We want to get them involved with PT and OT. Like I said, they're likely going to have NSAIDs, corticosteroids, and anti-rheumatic drugs like DMARDs, which is a disease-modifying anti-rheumatic drug, and or biologics. So the complications that these kids could see are other organ damage. So the inflammation that is happening can get into other organ systems and cause really bad problems like pericarditis, pericardial effusions, pleurisy, and pulmonary fibrosis. We're also going to see the visual issues. So we make sure that they do really good follow-up with specialists, and that when we see them in the hospital setting, we are evaluating their heart and lungs just as much as we are their joints. All right, lupus, systemic lupus erythematosus. It is a multi-system autoimmune disorder that affects both the humoral and the cellular immunity. So the kids' antigens, it causes the autoantibodies within them to react, and then those form immune complexes, and they fill up or congregate in the tissues and the organs, and they cause vasculitis. Sometimes they think that SLE can be precipitated by drug reactions, infections, or excessive sun exposure. The risk factors are being Black, Native, Asian, just basically non-Caucasian, Hispanics as well. have pretty severe disease. This is not to say that a Caucasian does not get SLE, but frequently we see more severe disease in people of color. Females are at a higher risk than males, and we tend to see, at least in the pediatric population, the diagnosis tends to start between 9 and 13 years of age. These are the cues. So during flares, we see what's called the malar rash, and that looks like a butterfly, and it is over the nose and cheeks. And it tends to be red and kind of hard and a little scaly. We can also see discoid lesions, which basically means just little lesions that are shaped like a disc. That's a different type of lupus than systemic, but systemic lupus can also have some discoid lesions. There's oral ulcers that are normally painless that develop with SLE. They have a history of fatigue, frequent fevers, weight changes, pain and swelling of their joints, numbness, tingling, and coolness of the extremities. So we're looking at neuropathic stuff. And then prolonged bleeding and frequent infections. So our laboratory findings are likely to show us that there's a decreased hemoglobin and hematocrit, decreased platelets, decreased white blood cells, decreased complement, which is the C3 and C4, and there's occasionally a positive ANA, which is an anti-nuclear antibody. The actions and interventions that we're going to want to make sure we do as nurses is to provide long-term supportive management. It's really hard when they are diagnosed in childhood with SLE. It's just a lifelong battle. We're going to try to prevent and monitor for complications. We're going to educate the family and the child on the importance of maintaining a healthy diet and regular exercise. Those things are really important for patients with lupus. Maintaining a regular diet and exercise means that they don't get as chubby as some of us tend to get with autoimmune diseases because of the constant corticosteroid use. So when we're bigger, it's harder to move our bodies and it's harder to help our joints because we're putting excess strain on them. We're going to educate the families about appropriate sleep and rest periods and medication management. We need to make sure that they understand that this, because it is long term, they need to use their medications well. Don't use them sporadically. It needs to be on a schedule and it needs to be done so that they can feel normal. We want them to use daily sunscreen because the skin exposure can lead to flares. We want them to limit their sun exposure. We also need them to protect themselves from cold because someone with SLE also has things that kind of sound and look like Raynaud's. It's because of the vasculitis overall. They have difficulty getting blood to the capillary system. So we need them to protect their tootsies and their fingies from the cold by using good layers and gloves in the wintertime. And then if they've been in the cold for a while, they need to come inside and actually inspect their fingers and toes because they might need to be warmed up slowly and methodically. We're going to monitor these patients for nephritis because the corticosteroids and other anti-malarial medications can cause issues with their beans or their kidneys. We want them to have annual evaluation of their eyes, not just by an optometrist or a doctor. They need to be seen by an ophthalmologist. And then we want them to take NSAIDs, corticosteroids, anti-malarials are like Plaquenil. And then the corticosteroids are usually going to be done as a high dose pulse during a flare. And those are really uncomfortable and they cause a lot of facial swelling and weight gain and just, it's not great. One of the other things that we need to watch for is these complications. So ocular and visual changes, we want to make sure we're asking them every time we see them, how's their vision? Are they having blurred vision, double vision, things of that nature? Are they having blind spots? These patients are also highly at risk for CVA because of the vasculitis. So we want to make sure that everybody who cares for them knows that they could have a cerebrovascular accident, and we want them to know what the signs and symptoms look like and what we need them to do if it occurs. They are at risk for transverse myelitis. They can also develop glomerulonephritis because of their immune complex. They can develop pericarditis, valvular heart disease, coronary artery disease. Another thing is because of the prolonged corticosteroid use, they can develop avascular necrosis of the joint space where they don't have any blood flowing to it, and then they'll lose the ability to mobilize on that joint. So we really want to watch for joint health and check their ability to mobilize. These kids can also have seizures and psychosis related to the vascular involvement to the brain. So there's a whole lot going on, and we just really need to make sure that they have good support, good education, and that they are always letting us know any abnormal complication or any abnormal cues that they've noticed, um, like a new joint pain that's never been this way before. They need to let someone know. Oh, and they cannot receive any live vaccines, right? Because they're on steroids. So any of these patients that we've talked about, the idiopathic arthritis or this SLE patient, if they are on a chronic long-term steroid, they cannot have any live vaccines. You have to wait 2 weeks after cessation of a steroid to be able to receive a live vaccine. Okay.